So, welcome. This is our, I think, third MEEDAH meeting. It's kind of an interesting way to call them MEEDAH meetings. I have muted everybody so that there isn't interference, from extraneous noise. Sometimes if you don't do that, you hear children and dogs and other extraneous things in the background that are very distracting. So we don't want that to happen. There is a way for you to get my attention. I think something on your screen allows you to put up your hand. Trouble is, I get going on these webinars and I don't notice it. So there's also a way to do chat, and you can send me a question on chat, which we probably won't do anything with until the end. I wish that I could be more spontaneous. I'm going to learn how to do that. So it's just me for now. This is not going to be a real long affair. But let's get going. This is what we're going to do today. We're going to talk a little bit more about the hidden healthcare tax because that sort of sets up the main item that we want to discuss, and that's the Medicare-Plus Disclosure bill, something brand new that we're hoping is going to work its way through with your help. And then a little bit more on how to use the MEEDAH.org website. Some of you weren't with us last time when we took a little tour. We won't belabor that, but I want to show you a couple of new things that we've just put up there that you're going to find useful. So let's talk a little bit about the hidden healthcare tax. This is all according to Minnesota Community Measurement. You'll see a copy of the booklet there on the right. That healthcare cost and utilization report is on the MEEDAH.org website on the agent's page. I'll show that to you later. I thought this was kind of fun. This is today. Look at that. Duluth News Tribune today. Let me see if I can go out and open that up for you. This is Beware the Hidden Healthcare Tax. It's an opinion piece. Written by Dave Racer. I know him. And is somewhat like the hidden tax article that we have on the website, on the MEEDAH website, only reduced in size and simplified a bit for public consumption. So this is something you can also access through the MEEDAH.org website on the agent's page. I think it's worth pulling down, reading, and maybe even circulating to your clients and friends and better people. What am I trying to say? People that you think should see it. Sorry, I opened the wrong screen there. Boy, you'd think I hadn't done this before. I guess I was kind of excited about that. I submitted this editorial to the Pioneer Press and to the Star Tribune. I didn't get anywhere. So then I went to the Duluth News Tribune, and they have a statewide circulation. So I know that editorial is being circulated statewide. What this report told us and what we talk about in the article is that the hidden healthcare tax on average was 87%. And that's computed by averaging the amount that Medicare would allow for a procedure and how much private health insurance actually paid for the same care. And this is from data in 2017. According to the report, this includes the actual cost, this is actual claims cost of 1.5 million patients and total spending of more than $8.6 billion. This is private spending compared to government spending. It's a pretty good sample size. I guess that's why we felt that these numbers were worth talking about. What we discover is that Medicare would have paid or allowed $4 billion less for those same services. So what private insurance paid $8.6 billion for, Medicare would have paid $4 billion for. Hence, that's where we come up with the 187% or 8.87% healthcare tax, as we're calling it. I want to be really, really clear. We're not suggesting that everybody should pay Medicare rate. That would collapse the system as we see it. What we're saying is let's be aware of the fact that private health insurance is key to maintaining the government-run health plans. We believe that 87% is more than it ought to be, and we're coming up with a better idea to reduce it. And I'm going to share that with you going into this lesson here. So another way of looking at this data was that claim cost in 2017 for those who were covered by commercial insurance, according to this data, was $563 a month. The hidden tax on that $563, if you want to put it into monthly terms, is $262 a month, with Medicare allowing only $301 a month for the same care. And there's that 87% tax computed in dollars. So in theory, if today's insurance premium is $1,000 per month, and let's say there's an admin cost of 15%, $150, that would mean that the claims premium is about $850. Well, insurance paid according to Medicare's allowed amount, reimbursing at the Medicare rate, would drop the premium to approximately $600, and $600 instead of $1,000. Well, you can imagine that people would be pretty excited if they could buy their insurance for $400 less. The trouble is they wouldn't be able to find a doctor or a hospital that could take them. And so that's not the resolution of the problem, but it is a description of the problem that private commercial health insurance is paying so much of the bill. Another way to look at it is for each $100 paid by Medicare on average, private insurance pays $187. And who actually pays this hidden healthcare tax? We like to say working people, people who are paying their own way, they're employed by employers getting a health plan, or they're on an individual plan. But these are the people who are on a government health plan, everyone not on a government health plan. Medicare, medical assistance, Minnesota Care, CHIP, VA, and all of that. In other words, your clients buying commercial health insurance are paying this $87% hidden tax. Uninsured individuals and everyone who has a private health insurance policy will pay the 87% hidden tax because they're going to pay the full amount. Now, here's a fact. When we talk about 187% of the Medicare rate, this does not mean that every provider in the state charges 187% of Medicare. Some charge less, some a lot less. Some charge more, some a lot more. In fact, HST has an article. HST is I believe it's a third-party administrator. Anyway, they have an article that shows in Minnesota, the average bill rate is 2 to 6 times Medicare. In some states, it's even more than that. We found in Minnesota even times where it was 20 times Medicare, by the way, the bill rate. And the huge differences are common in pricing. I'm going to show you from, I think these came from EOBs, and maybe this came also from the same study. A colonoscopy, commercial rates for that colon, it was from this study. Commercial charges, this is charged rate now, on those colonoscopies ranged from $289 to $1,853. This is not to say, just to be clear, the numbers I'm going to share with you are of the sample used by Minnesota Community Measurements in their report, but they are an indicator of what's going on out there with healthcare pricing. So for colonoscopies, the range was $289 to $1,853. That's a price variance, seriously, 641% for the same procedure. I would say done on the same end, but that would probably be crass. Medicare would pay $316 for that procedure. Isn't that interesting? Medical assistants would pay $247 for that procedure. And so that means that the commercial payments as a percentage of Medicare ranges from minus 8.5% to 586%. You say, well, Racer, you're throwing around a lot of numbers. Well, of course, this is a big part of the problem with healthcare pricing, that these prices vary so much. And as a reference base or reference price, Medicare shows us that price range is actually, in some cases, less than Medicare, and in many cases, a lot more. Here's a knee x-ray. The commercial rates were $29 to $378 for an x-ray. This is an x-ray, not an MRI. price varying by 1,300% from $29 to $378. Medicare was paying $32 for this, and medical assistance, $22. So the commercial insurance, again, has a range related to Medicare from -1% to 1,181%. So you can see, boy, these prices are all over the place. I'm going to share two more for you, or with you. Office exam, a 10-minute office exam. Commercial rates were $58 to $106, not quite the same range, 183%. I should point out that these are physician charges. Those others are facility charges. And I think you see that price range a lot more than you will, vary a lot more for facilities than you will for physicians. That's my experience anyway. Medicare pays $45 for that 10-minute office exam. Medical assistance, $34, which means commercial as a percent of Medicare ranges from 129 to 236%. Remember, the benchmark was 187%. So we were saying that was an average across all these things. And one last one, a complete blood count. So now we're doing a lab test. The range, this is unbelievable, but this is what we found. $12 to $119 for the same blood test, a price variance of nearly 1,000%. Medicare allows $11 and medical assistance $10 for this blood count screening. So commercial insurance as a percent of Medicare ranges from 109%, that'd be $12, to 1,082%. So these prices are all over the place. Here's another thing that happens with your clients, with you, when you go to the doctor. You come in and you're asked to sign an agreement, and the agreement essentially is an open-ended contract. The contract actually makes you liable for whatever the provider charges, but the provider doesn't tell you the price until long after, as you know, when you get the EOB, unless you take advantage of Section 62J.81 and you ask for the price before you get the care. This is an actual quote from one of those contracts that you sign. I also agree to pay any other balance not paid for by my insurance. And this is another one. All charges not covered by my third-party payer. Do you understand what I'm saying is every person who buys health care is going to be asked to sign this form along with other forms. Sometimes, in my experience, it's been one of two or three things on a sheet that I'm asked to sign, like direction of payment and that sort of thing. And then there'll be this statement down there saying that I'm liable for anything my insurance doesn't cover. But they won't tell me how much that is. So essentially, I've signed a contract obligating me to pay whatever the provider charges, and the provider doesn't tell me how much that's going to be. It's kind of crazy when you think about it. And it does result in overpriced care, and in particular to surprise billings. Surprise billing happens especially when you're out of network. You don't know what the price is, and your insurance only covers a fraction of it. Very, very nasty. So how the Medicare-Plus disclosure will be used. This is a bill. We've actually drafted the language. It's being, I believe, processed through the revisor's office right now to come alongside our reference-based price bill that we helped put together. This Medicare price disclosure, or Medicare-Plus disclosure, would only be used when a provider charges more than what Medicare allows. And you say, but isn't that everybody? Well, yeah, essentially it is. There are charges, as we saw, that are less than Medicare, but there's not very many physicians or hospitals who charge less than what Medicare charges. So the way this is written is when a provider charges more than what Medicare allows, they have to have you sign this statement. When a provider charges the same rate or less than Medicare, no Medicare Plus disclosure is needed, and that's probably never going to happen. When a provider charges more than the Medicare allowed amount, the Medicare Plus disclosure, excuse me for the typo, must be signed by the patient, not much be signed. So you're getting a statement essentially that says, I am responsible to pay all the charges, and our facility or our charges for those services are an average of or are 162% or whatever their percent is. And you say, well, why is that important? Because it actually allows us to pre-shop. And the bill requires more than just at the time of registration, by the way. Also, they're going to have to put it on their website and that sort of thing. So how it's used, the patient is able to shop for medical care by price, and not specific price, but price range, so that I know that, physician A, physician Anderson charges 140% over Medicare, is very happy with that. Well, physician, Benson charges 200%. And that allows me to ask that doctor, how much do you charge over Medicare? Well, that's the first question. And then what differentiates your medical practice from other providers in our community to justify your price? Supposing that I go to Dr. Rickert, and Dr. Rickert says, well, I get by on 90% of Medicare. And Dr. Kohout says, well, I get 200% of Medicare. I want to ask both of them, how do you justify that? I mean, why are you able to charge so much less? Why are you able to charge so much more? And Dr. Rickert says, well, I see patients in my kitchen. I'm sorry, I could get silly here, but they can justify the lower or higher rate. So under this new law, providers will be required to disclose the percent they will accept as full payment over Medicare's allowable reimbursement. Let me just read it again. It's really pretty simple. Under this Medicare-Plus Disclosure, providers will be required to disclose the percent they will accept as full payment over Medicare's allowable reimbursement. The acceptable rate has to be posted on the provider's website. The provider must immediately, when asked, disclose the rate to anyone who inquires. So inquiry can be by telephone, email, letter, or other form of communication. So I can call up clinics and ask what their rate is over Medicare, and then make a decision that way. And yes, it does mean their competitors will know their prices, because guess what? They'll shop their competitors just like grocery stores shop their competitors. It can create immediate price competition among providers. And you probably would see that great variation in prices shrink pretty quickly as patients start moving around. Now, that certainly is not the only determinant of why you go to a doctor or what their price is. Many of you know that I go to a cash practice doctor. In fact, I was going to go today for an ongoing problem with my nerve damage from surgery a year ago. It's been bothering me a lot. But then I told him, you know what, doctor? The fact of the matter is you're going to tell me this is just the way it is. It's going to take a while. So keep on doing what you're doing and you'll get better. So why should I pay for that, right? I'm making the decision, it's money out of my pocket. When you start making the decision, informed decision, knowing that you're being asked to pay 200% to a doctor, you're going to say, well, wait a minute, is that doctor really worth it? And maybe that doctor will change their price over time when they start losing business. Reference-based pricing insurance policies that are sold at variable rates, prices, that reflect the reimbursement rates paid as they refer to Medicare's allowed amount. So you can't really have a reference-based price insurance policy without knowing the percentage rate that a policy pays or that a provider charges. So let's say you have a Medicare-Plus plan. You have a charge that's $100, and you buy a Medicare-Plus plan that pays 120%. That's what it allows. That means you pay $120. That's all your plan will pay. Another one, $140, will pay $140. This is pretty simple math. A $100 plan, I'll pay $170. Let's say I've got that backwards. A 175% plan would pay $175. a 200% plan would pay $200. Now, you are all super savvy agents, brokers, consultants. You know that if the plan pays more, the premium is more. And of course, that's true. We aren't getting into plan design at all at this point. We are working on some documentation that way, and when it's ready, we'll share it with the world, but we're not quite ready yet. Well, I got to make clear, when I say we are working on this and that, I am not in the insurance business. You know that. I'm a teacher, researcher, writer, activist. My partner, Greg Datillo, is in the business. He is a consultant, but neither of us is going to be in the business of selling a health plan. There was a time when he and I talked about doing this as a general agent. We're not interested in that. In fact, I should be retiring. No, I'll never retire as long as I can keep doing this good work. So look at this screen that came up. Plans that pay 100% of Medicare would have the lowest premiums, obviously. And if they paid 50% of Medicare, you could never get service. So, but 100% of Medicare would have the lowest premiums. That's intuitive. 140% above Medicare maybe would have lower premiums, certainly lower than today. 175% will have medium premiums, and 200% will have the higher premiums. And I suppose in somebody's craziest wild dreams, they could do 250%, because frankly, we find that as a very common price. So you'll also have copays and deductibles and all of that. That's plan design, okay? All we're trying to demonstrate here is that the higher the rate of reimbursement, the more the premium will be. But it all relies on knowing what the rates are going to be. I got to go in the right direction here, excuse me. So why the disclosure bill is needed is to expose the hidden healthcare tax that patients pay that's not covered under a government health plan, to protect patients from surprise billings, to reduce the price of medical care through increased transparency. Transparency that is on everything, by the way. The problem with the new transparency law, which I know I've shared with you before, 62J.81, if you're not sure what that is, you go to Minnesota statutes. You can Google Minnesota statute 62J.81, and you can read it. I don't think I have that one on the website. Anyway, the trouble with that legislation is that they only disclose a small number of prices, and it's only certain physicians, and you have to ask to get the price. With reference-based pricing plans, you've got to know the percent above Medicare they charge. That's why the disclosure bill is necessary. Now, what to do now is to use these resources, but I'm going to show you something that may be a bit disturbing. I think you should be able to see this on your screen pretty well. I'm using a wide monitor here, so I hope that this doesn't bleed off on your side. In fact, maybe I can minimize it a little bit. This is House File, write it down, 2414. House File 2414. Otherwise known as Health and Human Services Omnibus Bill, that is being considered at this moment by your legislature. There are over 1,100 pages in this puppy. Can you believe it? 82 pages of it are specific to the issues that you and I have discussed and need to continue to discuss. So I have taken those two sections out of that huge bill, and I've compiled them together in one document called DFL HHS Bill Sections. I don't remember what all the title is, but I'm going to show you where you can get this anyway. So, you notice Article 9 is OneCare, and then it's got Article 13, and I hope that doesn't make you seasick what I'm doing. It tells how they're going to try to get advance payment state-based health insurance tax credits, state-based tax credits, and so on. I don't want to go through this now because it's really pretty detailed. I'd like to challenge you to go find it on the MEEDAH.org website. Last time, if you were on the call, I took you through this. I'm going to show you again a couple of things, but mainly I want to go right to the bottom when you go on the MEEDAH website and you see that little word down there, agents. So those of you who are brokers or consultants, I'm sorry. Agents was shorter, okay? When you go on this page, the agents page, in fact, you might want to bookmark that, MEEDAH.org/agents. That's pretty easy. This is the story of reference-based pricing and so forth. Some of the things you can leave with employers and employers. Okay, here's what I wanted to show you. This is that article I just showed you from the Duluth News Tribune. You can click on that and download it, read it yourself, maybe reproduce it if you want, leave it around. Here's the bill that I was just showing you. So you'll be able to click on it and pick it up just like that. What a deal, huh? And here's these other articles. The employee leave behind a hidden tax article from our website. That's a different version of this one up here. And this down here, I should have taken down. That's going to get confusing, forgive me, but because that's kind of the same one as that one. This is the one I actually got printed today. So, and then this is the Minnesota Community Measurements report that we referred to in the presentation. So this is last week's. If you weren't here last week, well, I guess it's more than a week ago, isn't it? Well, I can't do math. Okay, it's a couple weeks ago. This is the last MEEDAH meeting. If you weren't here, and I actually did go through that bill a bit, and if you want to review that. So that's all on there. And hey, I'm not even asking you to support us financially. We just want to get this information out, and for Pete's sake, we want you to use it with employers, with clients. If they don't know what's going on, the next thing you know, there's going to be anything going on. I'm guaranteeing you, I couldn't be overly serious because I like to have fun, but this is really pretty serious stuff. That bill that the DFL is pushing puts you out of business. I'm sorry. It has provisions for a small group. It has provisions for a platinum plan that the state will sell and try to pay doctors at Medicare rates. I mean, it's a heck of a bill. So, you know, go to those articles on the agent page and share. Oh, I'll go back to the About Us page. I want you to let me know what's happening in your town and your practice. Send me emails and that sort of thing. Listen, I'm a little older than I was when I used to work with you 10 years ago, but I'm still willing to come out and speak to agent groups, civic groups, and so forth. There may be some cost involved, but hey, this is a great time to get this message out. I've discovered that there's more interest now, and I've been told, by the way, it's the second highest issue on people's political radar right now. So download and read that article at the Duluth News Tribune. I want to go back to the MEEDAH website just for a minute. Since last time, we've had a few more agents sign on here to our coalition member page. If you go to the About Us page, we'd like to have your name, the name of your practice and where you're located, and add that to the list. We'd love to have a few hundred names on that list so that we can show the world we're not just a couple of guys tooting our own horn, which we're not. We're tooting your horn. And I mean that. We're really trying to be of service to you all. I am going to do something kind of scary, I think, if I can do this the way I want to. Oh, I'm unmuting you all now. We're going to start hearing some noise. Anybody have a question they want to ask me in front of the group? Anybody? Hello? Anybody? Okay, well, I don't want to embarrass anyone. If you don't have any questions, that's okay. Give me a shout out at well, you can use info@meedah.org. I'm going to go ahead and mute you again because it's just a bunch of noise now. Info@meedah.org, or if you have my regular email address, dgracer@comcast.net, do so. Please, please use these resources. We didn't get as big a group today as we had the last time. Last time we had a pretty big group, and maybe that I don't need to do these this often. I will do this again when there's something breaking that I think you'll find useful. So with that said, thanks a lot. I'm going to post this one online too. You'll see an email from me to that effect. So thanks a lot. Let's work together to try to save a private market healthcare system.